Yep. Now I have the honor of introducing yet another rising star, and it's kind of amazing the fellows that come out of these programs with these pioneers, obviously present company excluded, are really amazing individuals even at a young age. But I'm going to have Laura Fisher come up, who is another, like I said, rising star. She did her general surgery at the University of Wisconsin. She went on from there to do her Foregut fellowship with John Hunter at OHSU, finished in about 2016, I think, and already has made a big name for herself. She's also medical director of bariatrics. She's currently assistant professor at the University of Oklahoma. And like I said, it's a pleasure to welcome her to the stage.
Like everyone else, I just want to say how unbelievably honored I was to get the email inviting me to participate today, and this is really, really special, so thank you so much. So I have the pleasure of introducing Dr. John Hunter. Dr. Hunter grew up in Hanover, New Hampshire. His father was a prominent neurologist at Dartmouth, and he was raised by his stepmother, who was actually the executive assistant to the Secretary of State, who then raised Dr. Hunter and his 7 brothers and sisters in a full-time capacity. He went to Harvard for his undergraduate degree and then attended medical school at the University of Pennsylvania. He completed his surgical residency at the University of Utah Medical Center, and while there, he undertook a research fellowship with Dr. John Dixon, studying light tissue interaction, as well as the use of lasers in surgery, which is pretty cool. After his surgical residency, he actually completed 2 fellowships, one in flexible endoscopy at MGH, and another in ERCP at the University of Western Ontario. His first faculty job was at the University of Utah, where he was the director of surgical endoscopy. And 4 years later, he moved to Emory University in Atlanta, where he was the division chief of GI surgery. And during those early years in the 1990s, he pioneered the development of laparoscopic GI surgery and taught several hundred surgeons how to perform laparoscopic cholecystectomy. In 1998, he was the president of SAGES. He's the president of many other things as well. And in 2001, he was recruited to be the chair of the Department of Surgery at Oregon Health and Science University. He was the chair through the end of my fellowship year, and in 2016, he became the interim dean. After serving as dean for 1 year, he then transitioned to his current position as the executive vice president and chief executive officer at OHSU. We were asked to share a vignette of our time with our mentors, and my fondest memory of working with Dr. Hunter, which some of you may have heard me tell these stories before, is his demeanor and style in the OR. He is absolutely the most calm and measured person in any situation in the operating room. He never got flustered. I don't know that there was ever a single moment where he acted frustrated or was upset with me, the residents, the OR staff. And every single case that we scrubbed together, there always came a point where he would kind of very quietly say, "Hey, do you think I could come over to your side and throw a stitch?" And I was like, well, I'm not gonna say no to Dr. Hunter, right? So I'm like, of course, please, let's switch. And I kind of, over the year, I was like, gosh, I wonder if I'll get to do any cases completely by myself all the way through. And on the very last day of my fellowship, my last case was a Nissen, and we kind of got to the point where he normally likes to throw his stitch, which is the first stitch in the wrap. And he kind of stopped and asked if he could come over, and I was very happy to have him do that. So with that, I would love to introduce Dr. John Hunter.
Thanks, Laura.
You're welcome. So in thinking about these questions, I wanted to go back even a little bit further and ask you to describe what it was like when you first started hearing about this concept of laparoscopic surgery, and were you skeptical, or was this something that you immediately saw as the potential in, and what was your experience with that?
Yeah. Well, thanks. So I did my residency in Utah, as you said, and my mentor there was a fellow by the name of John Dixon, and John Dixon was a general surgeon who had a massive MI somewhere in the late portions of his career and decided he really couldn't be in the OR anymore, so he started doing endoscopy. He happened to start doing flexible endoscopy just as SAGES was being formed, and he was one of the founding fathers of SAGES. So he inspired me to think about doing surgery with scopes, trying to eliminate the incision. And there's a fellow that in private practice there at the LDS hospital called Walt Gaisford. And Walt did a lot of laparoscopy as part of his endoscopy. He too was a surgical endoscopist. So I went over and worked with Walt, and we did mostly diagnostic laparoscopy. So when we heard about the developments in France and in Nashville, where they were taking out the gallbladder, it became pretty natural to think about that. My friend Nat Soper had taken that up in St. Louis, so I had the chance to, Nat was kind enough to let me into his operating room to see how it all went, and that's how we got started.
So tell me about your very first laparoscopic case.
So one of the sort of, life takes very interesting turns, and one of those interesting turns was when George Bursey, who was, again, one of the fathers of SAGES and one of the early teachers of laparoscopic surgery, called me up and said, I'm having trouble getting all my courses done here in Southern California. I know you've taught a lot of laser courses in Utah. What would you think about moving all the courses to Utah? And so I said, yeah, that sounds good, but there's one issue. He says, what's that? I said, well, I need to be a student at the first course that I'm a professor at, because I've never taken out a gallbladder laparoscopically. And so lo and behold, Alfred Coucheri and George and John Sakier came up, and we taught the first course. And then the next day, George helped me take out the first gallbladder. And at that case, as we were looking up in the right upper quadrant, we identified this structure that looked like the gallbladder and put a grasper on it and pushed it up. And I said, George, I don't think the gallbladder has tinea on it, does it? At which point we said, we looked for a different organ. And eventually took out the gallbladder.
There were some challenges in the beginning.
Some challenges in those days.
How and when did you start performing fundoplications laparoscopically?
Well, Lee and I really started together, as Lee alluded to, and I was doing a lot of flexible endoscopy at the time and running into a lot of folks with erosive esophagitis. And our choices at that point were 6 weeks of omeprazole or open fundoplication. And given that, most patients chose 6 weeks of omeprazole. But at the end of that period, when the FDA said you had to stop that, they started having horrible reflux again. So I said, what are their options? I said, well, we're working in the lab on this thing where we can actually take a laparoscope and do this operation, and we think it's probably going to be a good thing, but we're not quite ready to do it. Alf Coucheri, again, who had been doing some in Scotland, was kind enough to come over to Oregon and help us get started. And so Lee and myself and Bruce Wolf and Alfred kind of put an early study together. I think we did 7 in Oregon, 7 in Utah, kind of going back and forth between Toupees and Nissens, and then published a series about it. But that's fundamentally what got us going. Yeah. I think that there's a kind of fun connection. Jeff Peters was also involved. Jeff, another Demeester disciple. And in between doing pig surgery, we usually followed that after one of our courses. We wrote lyrics for the lap rap. So the lap rappers and laparoscopic fundoplication were sort of born in the same pig lab, years ago. So
that's funny. What were some of the early challenges as you developed laparoscopic Nissen?
Well, I think there are a lot of technical challenges. I mean, we started with 0-degree scopes, for instance, and there are places where, posteriorly where we couldn't see. I think kind of understanding, as Tom said, understanding the physiology better to the point where we really were, basing the operation on the physiologic assessment of the esophagus rather than what we could do. And you know, initially we didn't mobilize the fundus in these operations. We thought this Rossetti Hell Nissen was probably a good thing, and turned out it caused a heck of a lot of dysphagia. I was going to say a hell of a lot of dysphagia, but you know, so that was a technique that we abandoned. But I think this sort of technique evolution was probably the thing that was most challenging, as well as some of the technology.
Yeah. I kind of, when I'm talking to my residents now, I explain kind of my thoughts on complex laparoscopy and the difference between doing an appy or a gallbladder and doing a gastric bypass or a revision Nissen is, I think there are kind of three main things. One is being able to do gentle bowel handling. Another is hemorrhage control. And then the third is the slip knot. I think the slip knot, being able to tie under tension laparoscopically, is one of the most important things that I use every day. How did you guys figure out how to do that laparoscopically?
Yeah. So this is another trail that leads back to George Bursey. So George we were all sort of challenged to tie knots laparoscopically in the early days. I remember we were tying surgeon's knots as our first knot, and you know, inevitably it would slip at the wrong moment, just as your second knot's going down. And so George had run into this fellow Hungarian there by the name of Zoltan Szabo. And Zoltan was in San Francisco, and he had recently taught the plastic surgeons how to do microvascular surgery under operating microscopes, so that they could sew fingers back on. And Harry Bunke was sort of the pioneer of digital reimplantation. So when George found Zoli took us to the lab, and we were doing microscopic microvascular anastomoses, doing this slip knot technique. And then Zoli and George said, well, let's go over and try this in a box trainer. And so lo and behold, it kind of got moved from the microscope to the box trainer to the operating room. And Zoli used to come and help teach in those courses as well, and often started people off under the microscope. So.
And on a similar vein, how did you develop the Hunter grasper?
So again, these things are all a little
ubiquitous Hunter.
They're a little bit gratuitous, as much of science or much of developing, kind of being in the right place at the right time, I guess you could say. And there's an instrument company out of just outside of Atlanta called Solos Endoscopy. And Solos was really the first to make a wide variety of sort of DeBakey-like bowel graspers. But they had some shortcomings. They were sort of traumatic on the end, and they were a little bit delicate. They broke fairly frequently. So Howard Jamner, who was a instrument maker from New York, loved to ski. And he came to Utah to ski, and I think he wanted to write off his trip. So he arranged a 1 hour, half-hour meeting with me and said, what instruments can we make for you? So I pulled out a Solos grasper, and I said, let's try to make this better. And so we went to work and made it better. And the key in figuring this out, as I think most surgeons in the room know, is if you wanted to figure out whether an instrument's traumatic or not, you apply it to the skin fold between your first finger and your thumb. And if it doesn't hurt, then it's probably a good bowel grasper. And so that was kind of our litmus test that we've. But with that, the 2.5 centimeter jaw length seemed to work out pretty well.
What do you think, in your current practice, when you're teaching laparoscopic fundoplication to residents and fellows, what are the key points that you really try to emphasize in terms of doing a good operation? Yeah. Well, I think the first, and this is kind of, it goes back to, Halstead's techniques of immaculate hemostasis, traction, countertraction, adequate visualization, is really setting up the operation in a way that you can really see what you're doing. Mm-hmm. And I think all of us remember that early in the early days of trying to take that highest short gastric down, and how it was not infrequent that we struggled a bit or got a little bleeding up there. But over the years, just learning how to expose, how to set that up so that you can really see what you're doing. And when you do that, I mean, you alluded to the fact that I was generally calm in the OR. I was generally calm in the OR because we had the exposure that we needed to have to do what we wanted to do. And the instrument and
the techniques and the experienced fellows to really help us. So I think that's really key. And then I guess just sort of the dissection techniques that were really not a whole lot different than open. Dissection of the crura, adequate esophageal length, using the collis extension if necessary, adequate closure of the crura to prevent reherniation, placement of the fundoplication below the diaphragm. It's interesting, Lee and I have evolved in different ways over the years. I evolved to put one more stitch in, so we put in 4 stitches instead of 3. But it's not to say that 9 isn't the correct number. But I think that sort of the geometry of the fundoplication, that when done right, kind of keeps it in the right place.
Yeah, I think the benefit of doing fellowship is being able to see many, many, many cases, and you kind of get a sense of what looks right.
Yeah.
Tell us about your 4th stitch.
Oh, well, the 4th stitch was again, as Lee says, something happens and then you take a look at it and you evolve your technique. I had a fellow, very young fellow with reflux disease who retched shortly after surgery, and the front part where we'd secured it to the esophagus remained intact, but the back part of the fundoplication just completely had slipped off. It sort of de-intussuscepted, if you will, and stripped it off, and it caused a foregut obstruction right there at the GE junction. So I said, well, it makes sense to sort of see if I can make sure there's securing the fundoplication to the back of the esophagus with a single stitch, just to try to prevent that. And again, haven't had that happen since then, but who knows?
I like your mesh placement. Can you describe what you do right now with mesh at the hiatus when there's a lot of tension?
Yeah. Well, I got to say, the first thing is that we don't really know what we're doing here, and let's just start with that. We've tried lots of different ways to keep paraesophageal hernias from recurring. And those expensive techniques, like $1,000 pieces of biomesh, you can often get a company to support, or we could get a company to support trials, randomizing one to the other, those trials largely showed that there was no difference over time between sutured repair and these mesh repairs. But it's very hard to get when you're using cheap plastic mesh, to get a company to support that. We have adopted a technique that was used by some Austrian surgeons, which is just a single piece of Paritex that is 5 centimeters by 1.5 centimeters that just bridges the top, so buttresses the top of the crural repair, and is mattress, put it in with a mattress stitch. And again, no randomized data. We really have seen very few symptomatic recurrences. Again, we don't study everybody like we would on a randomized trial. So I'm not sure how well it works, but it seems to work pretty well.
Yeah. So. Well, I like how you incorporate the mesh into the last stitch at the top of your cruroplasty. What's your, we have just a couple minutes, what's your current kind of algorithm for dealing with patients who do have symptomatic recurrence or who are on their 2nd or 3rd revision? How do you decide who to offer surgery to, what surgery to choose, and what's your bailout if you don't think you can do a safe revision? Yeah.
I think the first and most important thing in deciding about revisional surgery is finding something you can fix. So if a patient has an intact-looking fundoplication, endoscopically, radiographically, especially with pH studies, but even if the pH study is a little bit abnormal and you don't see anything fundamentally anatomically wrong with the Nissen, I think it's unlikely you're going to make them a lot better. So the most common reason for doing revisional surgery is the recurrent hiatal hernia. And usually people can track that. They felt great for 3 years, then I had a vomiting episode, or then I threw a bale of hay, or I did something or other, and then I just started having reflux again, and you get the barium swallowing, the left side of their fundoplication is up in their chest. So I think that's the key. What do you do differently the next time around? Say it another way. You try to do something a little bit differently, and frequently it's the esophagus is foreshortened. Again, the reinforcement of the diaphragm with the mesh, things that we add second time around. was third time around, rarely, thankfully. But those are probably the two added tricks we have. Again, Lee's work on, or suggestion that you have to understand the physiology of the esophagus and the stomach is really important. I think what Tom DeMeester taught me years ago was that if the esophagus doesn't work, get rid of it. If the stomach doesn't work, get rid of it. So in those real salvage situations, you kind of see which organ's working. And there are obviously situations where you're trying to, this patient's just, either has a blown esophagus or a blown stomach or both. Whether do you do a sort of a gastric bypass type technique, which is if the stomach's gone, that's sort of your bailout option, or lo and behold, every once in a while you have to do an esophagectomy for someone who just has no esophageal function left.
My last question is, how is it now that you've gone over to the dark side of administration?
Don't answer it.
That's right. It's that Pogo cartoon, I've seen the enemy and it is us. No, I think that was, again, it goes to the comments I made yesterday. When you're asked to serve, you serve. And I never aspired to be a CEO of a hospital, I can tell you that, or a CEO of a health system. But when the president of the university asks you to do it, and you step up and do it. I think the opportunity there is to do, we've all been frustrated over the years with hospital administration, and I'm the first CEO in our institution that's ever practiced, and I still practice. And it's all the more important that you allow me to do my stitch, by the way, right now. But remember how to do it. That one stitch. It's a whole different world, but it's the opportunity to, again, do something that makes a difference on a grander scale in some ways is there. But just that touch that you get as a surgeon to a patient, never lose that. That's the most valuable thing, I think.
Well, they're lucky to have you.
Well, thank you very much for the chance to do this. And
thank you.
Thank you guys very much, Michael and John. Thank you.
And congratulations, if you don't know, Dr. Hunter won the prestigious George Bursey Lifetime Achievement SAGES Award this year, and well-deserved, and yeah.